All right. So, hello, everybody. I hope you can hear me. Hello and welcome to the 38th Annual AIPNO Gala and Educational Series. And it's my pleasure to introduce fantastic speakers that we have this year. With me is Dr. Neil Mehta, co-chair of this program and Associate Dean for Curricular Affairs at the Cleveland Clinic Lerner College of Medicine and Case Western University, and the Director for the Center for Technology, Enhancement, Knowledge, and Instruction. He holds the Jones Day Endowed Chair in Medical Education at the Cleveland Clinic Lerner College of Medicine. Hello, Dr. Mehta.
My pleasure. Pleasure to be here. Thank you.
We are very thankful to have a host of highly knowledgeable and thought-provoking speakers today. Dr. Stephen Gordon, who's the chairman of the Department of Infectious Diseases at the Cleveland Clinic, and Dr. George Thomas, the director of the Cleveland Clinic Center for Blood Pressure Disorders. I must also thank Dr. Dharmesh Mehta, the president of AIPNO, for his leadership and hard work of his team throughout the year, and a wonderful job indeed. I must thank Dr. Past President, Dr. Rupesh Rana, and President-elect Dr. Vinnie Macon for her help in sourcing the speakers. And thanks to Chetan and team for the virtual platform and the AIPNO committees and BOT and Dr. Mukunda. And I must definitely thank our sponsors for this event, including Dexcom with their continuous glucose monitors, Mankind with their unique inhaled insulin, and Novo Nordisk with their only oral GLP-1 Rybelsus, and the US Medicine Supply Company for helping out and making this event better for us. I could not have done this without the diligent work that goes into raising funds and making this possible from my business partner and my wife, Namrata Kumar. So thank you, all of you. Now to the educational series. I welcome Dr. Stephen Gordon. Hello, Dr. Gordon. We are honored to have you here today to enlighten us on perspectives on COVID. Dr. Gordon is a highly educated expert in the field of infectious disease, and he will be giving us his knowledge, and you can have any interesting questions you want surrounding COVID. A little history about Dr. Gordon. He earned his medical degree from Cornell University in New York, and then he went to do his fellowship at the CDC in Georgia. Additionally, he's a member of many professional organizations, especially the Society for Healthcare Epidemiology of America, of which he was the president in 2011. And he has received a number of honors awards and published more than 160 articles and multiple book chapters. He was most recently appointed to serve on the Defense Health Board, which serves as a federal advisory committee to the Secretary of Defense. I will hand it over to Dr. Gordon. Thank you.
Well, thank you so much. And it is a pleasure to be. Can you see my slides?
No.
Let's see. Let's try that again then. They were there. What about now?
Yes.
Okay. I'm going to leave. Okay. Well, thank you so much for the kind invite, and we have a nice intimate group today. It's kind of for me bringing coal to Newcastle here, since obviously I think everyone is pretty well educated on this topic. So I hope just to bring some perspectives. Obviously, want to start with wishing everyone a happy and safe Halloween. I have no conflicts of interest and do want to acknowledge all my bright colleagues here that have kind of helped us, as well as everybody, to learn about things in terms of on the pandemic. In the next 20 minutes or so, I'll try to just cut it down to kind of my lessons learned, a brief issue on treatments, a little bit more updates on the vaccination boosting in immunity, and with trepidation to talk about forecasting, not predictions. As level setting, I think we all know, obviously, the disease is the COVID-19. The virus is the SARS-CoV-2. And it just interesting perspectives now. Now more people have died here, at least in the homeland, from SARS-CoV-2 than in the 1918 pandemic. Of course, as a proportion, it's still higher in 1918. But these curves from Christopoulos' book, which is a very interesting read, kind of just show you the issue of severity versus transmissibility on the left of previously respiratory pandemics. And as I said, the 2020, now 2021 pandemic is equal in terms of total mortality as the 1918. The difference, however, I think is highlighted in the next curve, where This pandemic, in terms of mortality curve, is really what we call a backward L, meaning that although some children have died, in the United States, it's estimated about 200, the majority of death is associated with increasing age for people like myself above the age 60. And that is actually probably a good thing, because if this was equal killing across, especially our children, it would really create more psychological havoc. And I think, as we all know, here in the homeland, life expectancy actually fell by almost a year in 2020, almost 3 years for people of color, and 1 in 500 Americans died of COVID-19 in 2020. Putting these trends in numbers, 700,000 and counting here, globally close to 5 million. And for the last 100,000 tranche of deaths here in the homeland, it took about 100 days. And the difference there is 40% were less than those 65 years of age, which was the largest proportion since we've been looking at these 100,000 kind of death slices, and less than 3%, importantly, amongst the unvaccinated, amongst the vaccinated. And again, in terms of matching this up here in the homeland about causes of death, the third leading cause of death in 2020, only behind heart disease and cancer. Fortunately, as we said, although children are increasingly percentage of the number of positives of new cases as we move forward, in part because obviously no vaccines for those under the age of 12. Fortunately, again, severe disease in children, although occurs, is still relatively unusual. All right. So from my perspective, why has this been such a difficult thing for us to, contain? And I think I break it down into 5 big variables. The first is it's truly a novel disease. There is no pre-existing immunity that any of us could have harbored to help mitigate effects of infection. The second is the issue about transmission without symptoms. Third is some of the early on, not probably an underappreciation of what we'd call the non-respiratory presentations of COVID-19. Fourth, of course, is globalization. And now fifth is the issue about variants of concern and immune escape. So from an epidemiology point of view in infectious disease, we talk about the incubation period where you're infected but not symptomatic. When you become symptomatic, obviously, we all get our cold or sniffles. And there's that latent period where you're truly not infectious. For SARS-CoV-2, there's that mismatch period, which is longer than other respiratory viruses that we're used to, where you're not symptomatic, but you're still infectious. And this drives about 1/3 to 40% of transmissions, and is one reason, especially in households where the virus continues to propagate, why it's so difficult to control. By the time you have symptoms, you've already effectively have spread to your household contacts. The other interesting thing, which is still evolving, is the myriad of presentations. Although as we anchored on a respiratory illness early on, quickly we saw almost all parts of the body could be affected even without respiratory symptoms. The anosmia now gets a new attention. And in fact, we kid ourselves, if we were really trying to screen patients, probably more effective than thermometer would be to have people have to smell aromas in terms of this. This also precludes what we would say the quote unquote long hauler syndrome. And I think this is another important aspect. Even in healthy young people, was appreciated early on that after 3 weeks, 1/3 of healthy people are still going to have a lingering symptom. And when we talk about now what we call prolonged COVID, that definition can be beyond 90 days. But as you know, we're describing large cohorts of people that never get back to normal. Some of this we can identify on lung CTs and lung functions. Some other, I would say, is just more the non-specific fatigues that we see in other post-infectious illnesses. But the long hauler clearly is an issue for millions of Americans and millions of people across the world. The other important thing, as you all know, of course, is the importance of our integrated economy and just global migration and travel. So when we talked about SARS-CoV-1, which in many books is identified as the first what we would call jet set disease, going back, you remember in terms of the Hotel Metropole in Hong Kong, how the diaspora went to South Korea, to Vietnam, and then to Toronto, and then miraculously kind of disappeared. But when we fast forward 20 years, I mean, Hunan, China is a city of 20 million. The number of people in global migrations is huge. And it was kind of, in retrospect, naive of us to think that if you had a big outbreak in a place like Wuhan, China, that it wasn't already here in North America and Europe, and indeed it was. So we had our blinders on, and that's, I think, another lesson learned. The other factor, of course, is the emergence of variants, and not all variants are going to be effective or necessarily attribute into more transmission or more virulence. But look at the effect here of Delta, which we had the harbinger, obviously, in the UK. But you can see in July, many of us were thinking, oh, my goodness, this is going to be good. Light at the end of the tunnel, good summer, mask down if you're vaccinated. And then within 8 weeks, hot zones. And again, as it turns out, during the Delta period, it probably is not more virulent. But what was happening is, especially between 18 and 49, unmasked, unvaccinated were driving a lot of disease and certainly more transmissible. And as you know, although there are other variants of concern, here in the homeland still, it's probably still greater than 95% of our genomic analysis is Delta. And so this, to me, we talked about lessons. And for me, I think as an organization as well, it's humility, gratitude, and love. These scenes were taken pre-pandemic when I was in Medellin in Colombia, and there's a wall of love. But just as Dr. Kumar says, acknowledging his loved one, I mean, I think all of us now hopefully take the time, be humility. Whenever we make plans with this virus, we're always kind of frustrated, and making sure that we tell the people we love them today, appreciating the simple things. So I think that to me has been the greatest self-reflection lesson over the past 20 months. And I won't bring up, I'm not here to take sides or anything else, but as we all know, you know, it's about playing the game. And even if you're favored or the underdog, you can always learn something from failure or from even from winning. And that's important. The most important thing is, as I look at these two proud teams, is playing the game together and in terms of this. So you can be competitors, but also learn from one another. So I think that's all I will say about the cricket. But I do think, you know, this slide came off of a nice kind of leadership course from last week from Maya Angelou. And I think it's important. All of you are leaders in terms of this. But I do like this quote here. I've learned a lot that people will forget what I say today. They're going to forget what I did when I'm gone. But they'll never forget how you make them feel. And all of us as clinicians, we know that you know, the patients don't really care how much you know until they know how much you care. I mean, you know, from Peabody, I know Neil teaches that to all the learners in the medical school, and this is kind of our ground zero, and it's been really reinforced again in the pandemic. Now, I love the tribute to Dr. Kumar's wife, and we've learned a lot of, I think, also lessons about leadership in the stronger sex, which is the female sex, in terms of how they've handled the pandemic, and we've got great leaders. Just of note that less than 10% of the 200 nations are led by women, and I think that's an opportunity similar to less than 10% of the Fortune 500 companies. We see a change here in the clinic. We see a change in all our departments. We know, and Neil can tell you, for the first time in American history, there are more women matriculating in American medical schools than men. This trend will continue. And so whether people like that or not, I think it's having 3 daughters. I'm biased. But I think this will be a good thing for medicine. And let's pay some respect and specifics to the pandemic. The first person to actually see the quote unquote knobs or the corona of coronavirus, how it got its name, was a virologist, June Almedea. That was over 55 years ago. And you can see still the iconic electron microscopy of that coronavirus. And then as we look at vaccine development and mRNA technology, there are women fingerprints throughout. The husband and wife team of the Pfizer-BioNTech product, right? In terms of Dr. Carrico, very instrumental in the background work over 20 years of the mRNA vaccine. Dr. Gilbert, who really designed the Oxford adenovirus vector vaccine, and Dr. Corbett with the NIH Moderna. So STEM women, this is a great thing, I think, and very highlighted by the pandemic. The other thing I think, you know, as an old clinician, I always talk about my clinical observation and common sense. But as we all know, that does not stand up to randomized controlled trials. And the fails for common sense and observation are biased on measured confounding, failure to understand the total risk within complex system, and of course, incomplete understanding of the basic science, which then leads to errors or maybe misinformation. And we all know many examples during these past 18 months were probably led to patient harm. The ivermectin story, interesting podcast from the Daily last month. But as you know, this really picked up steam later this year, probably more of a cancel culture than science, but nonetheless was picked up by conservatives as snuffing things out. In the largest first study that showed clinical outcome that got a lot of steam, the Egyptian study, as you all know, was retracted, fabrication, but it doesn't matter. You don't print that after it's printed on page 1. And look at the amount of ivermectin dispensed here in the United States, 24-fold time baseline pre-pandemic, including, we know, the run on actually veterinarian ivermectin and issues with overdoses. This gets me to treatment, and I'm not going to spend a lot of time on treatment except to say it's been disappointing to date. We've got one FDA-approved antiviral, remdesivir, which was not designed as a SARS-CoV-2 drug, as you know. It was an Ebola drug. The basic things that have saved lives are our ICU teams in terms of proning, mechanical ventilation. And some of this was a mismatch for monies. Appropriately, I think a lot of money directed toward vaccine development, which has been successful. Now we're starting to see some catch up, I think, in targeted modalities for antivirals. This slide kind of outlines the raison d'etat where we think about simplified in terms of where targeting should go. As you know, the highest viral loads start out with COVID at the beginning, unlike SARS-CoV-1. So antivirals usually detected there, or antibodies before antibodies are developed within a couple of weeks. Then moving toward potentially in the sickest patients, things that may mitigate inflammatory response, such as the JAK2 inhibitors or things like the IL-6 inhibitors that have been used, as well as steroids. I'll just leave it here. This was from our ICU, Eduardo Miracles. So it's a very good kind of, I'd say, high-level slide in terms of interventions, pre-infections, obviously vaccination, in non-pharmacologic interventions. Monoclonal antibodies can be used also, in terms of early on before somebody gets sick. Then obviously using more mechanical intubation when needed, remdesivir, steroids for those with pneumonia and requiring ICU, and finally some of what we'd say the anti-inflammatory drugs such as toci, baricitinib for those that are we'd say sick, ventilated, and still within 10 days. Even as good as we are, this is something that obviously people die from. So mortality, highest mechanically ventilated. Even the survivors have a lot of prolonged length of stay. And this has really jammed up our ability to deliver care for other disease processes. And although, as we talked about earlier, the increased deaths in America, third leading cause of deaths was COVID. But remember, there was also unexpected increases in heart disease, neurologic disease, and a lot of that was attributed to access to care or people afraid to get care. So some of that was also an indirect consequence of fear and capacity. I'm not going to talk too much about ventilators and prone, and I'm not going to talk again. I'll skip over the JAK inhibitors. I think this is interesting, but we have our own flow sheets, and this is just an eye chart in terms of how decisions are made in the sickest patients in the ICU. Tocilizumab, as you know, is used in cancer patients for CAR T therapy, and we have to save our doses for that. That has driven us to use what we'd say substitutes for toci when there's shortages in creating things like baricitinib and sirolimus. In terms of neutralizing antibody, this is probably the one treatment we do have for outpatients, obviously, and this is really reserved in the early phase before our own antibodies can be made in people at high risk for developing severe disease. It's pretty liberal at this point in time, but it was initially reserved for say, our very immune suppressed. A single dose infusion, and this is the Regeneron drug that we find it kind of interesting that many patients who don't trust the vaccine are more than happy to get an EUA with a monoclonal antibody after infection. We've expanded use now. There's our epidemic curve in the lower right. And so, you can see that over the Delta period, we really had an increase. It's beginning to flatten off a little bit. Early documented infection is really where it has the greatest, what we'd say, bang for the buck. It's now being used for prophylaxis in some circumstances for people at high risk that can't respond to vaccine, and some sub-Q and IM administrations are being developed, as well as long-lasting depot preparations. Again, no substitute for vaccine, but does have a place in terms of our armamentarium. Not going to go through this eye chart. This is just for reference in terms of how we make some of those decisions. And again, the next slide shows us in terms of eligibility steps and things of this nature. Okay. In terms of other agents in the pipeline that have gotten some press, the oral antivirals. So everyone is talking about molnupiravir, which is actually, for those of you who are scholars, is named after Thor's hammer. It is a kind of a ribonucleoside analog that targets the viral polymerase, so it does shut things down. One study have not seen the preprints at all. It was published as a poster at IDSA a couple of weeks ago. The study was aborted because endpoints were reached, a combined endpoint of either death or non-severe disease. Again, these are patients at high risk, so not a lot of details. It's now out in front of the FDA. The U.S. has already bought, I think, about 2 million doses in anticipation. So I think it will have a role, but again, it's not going to be a substitute for vaccination. Pfizer and ATA also have oral antivirals in process, but our experience, as you know, with antivirals for other things, such as influenza, it really doesn't save lives. It may cut down on symptoms, and resistance, as we all know, develops, and there's no reason to think that won't happen here. Nanobodies, which come from camelids or llamas, interesting immunoglobulins also being looked at, as well as inhaled interferons, but none of these are off the shelf at this time. This slide, I think, is also framed how we've approached the pandemic and how we approach any adverse outcomes. This comes from Reasons, the British hazards master who looked at how to prevent adverse outcomes and putting up different barriers that will help, quote unquote, align the holes in each of the Swiss cheese for adverse outcomes. As interns, we all remember if I gave a drug and there was an adverse outcome, we would always be at the short end of the stick and people would say, what the hell did you do? You felt terrible. But we all know in systems thinking, it's always good people, bad systems. And the hope was, of course, the personal responsibilities about distancing, masking, and then some of the governmental about shutdowns, that the vaccine itself would be the greatest piece. And vaccines have been great, but as we all know, has not been a panacea. I like this book by Eula Bliss. This was published before the pandemic, and this shows, of course, Thetis, who had pissed off a god, and she's dipping her son Achilles into the river Styx to kind of immunize him. So although maternal fetal antibodies are clearly God's immunization, this was probably the first active immunization in history. And it worked well, except for the Achilles heel probably 25 years later. And I think all of us, all of us ascribe, I think, to the WHO. No one is safe until everyone is. This just doesn't include COVID-19. This would include any type of big outbreak. And again, providing widespread global availability, high community coverage with safe and effective vaccines is really the universal goal. Right now, from the latest statistics, only about 50% of the world's population has received at least one dose of a COVID vaccine. And again, this just shows the open spots. No surprise, Africa is at a shortage versus the green, which is the developed world where there's high vaccine coverage. Won't go through the vaccines because there's many series. I mean, the mRNAs are the ones that are becoming our workhorses, but obviously the non-mRNA vaccines are available. And I do want to bring up Novavax because the world's going to need a different vaccine for boosting that doesn't really rely on a fastidious cold chain in technology. And the protein subunit vaccine, which is in current studies now, looks pretty good. And so I still see a bevy of different components in a mixed mass strategy. The CDC Health Advisory also highlights pregnancy, which has always been a hard target for us to get at for vaccines because of misperceptions. But this is important because whether you're trying to get pregnant, whether you're lactating, or whether you're thinking about getting pregnant, getting COVID is not a good thing for either the mother or the unborn child. So this has gone from what we'd say a neutral recommendation early on to a very strong recommendation. And here in America, probably only a third of pregnant women have accepted or received a COVID-19 vaccine. And all of us have seen pregnant women die or go on VV-ECMO that are unvaccinated. In terms of effectiveness, I like this study out of Lancet, which kind of was a meta-analysis looking at, in the 4 quadrants, vaccine efficacy. This was against severe disease, whether against the type of variant of concern in B, whether or not you got a protein subunit or what type of vaccine, or whether you got the vaccine early or late. And all of these, again, show protection against severe disease and death for any type of these vaccines, which I think is important. Infection is a different story, and we've all pivoted from this as a sterilizing immunity vaccine to more preventing severe illness and death, which is really the clinical endpoints that I think all of us care about. So what we're pushing for, unvaccinated versus vaccinated, 16 times rate of hospitalization or greater than 10 times rate of death and greater than 6 times risk of infection. These are really the good clinical outpoints. And of course, CDC has always provided us with what I call the great stories, you know, because the public needs a story. So I love reading the MMWRs. In this case, a non-vaccinated symptomatic school teacher reading a story out loud en masse to her masked but unvaccinated children, showing the power of Delta in terms of spread. And even traveling recently, as you go through O'Hare, even the dinosaurs are wearing masks. So old people like me, you can teach new tricks. I think that that's important, good messaging. In terms of boosters, we talked about, I like this slide from Michelle Medina. You know, we already have all examples of insufficient response with a primary series, HPV, right? I mean, if you're over the age of 16, you actually need more, an extra dose than under the age of 16. Waning immunity, all of ours who are grandparents all got our Tdap before we were able to hold our grandchildren again because of the pertussis. In vaccine efficacy against a variation strain, every year our 4 strains in influenza, they're changing that by circulating strains. So these concepts are not new, and I suspect for COVID-19, we're going to see the same concept. This is probably will turn into an annual immunization, probably linked with flu, and probably a polymer that is like influenza with more than one type of strain in the quote unquote boost. All of us who see immunosuppressed patients know we've seen breakthrough vaccine failures with severe disease. No surprise there. This has been a perpetual problem with many of these patients. But again, I like this old review by Stanley Plotkin and highlighting that, you know, we have immune correlates, you know, so we can measure antibodies. But what we really care about is immunity, and that's just protection against disease. And I just want to highlight, and actually CDC just came out today with reinforcing this. You know, there's a lot of tests for correlate of protection. We still don't have a unified available test that you and I can go get a point of care test to know that we're immune or not immune, like hepatitis B. I think that will come in the future, but we don't have that. And some people who have been using this, and there's a lot of people that do, maybe falsely assuring themselves that they're protected or falsely worry themselves that they're not. So this is one of the lacunes, I think, right now. We don't have that blood test that's a correlate of protection. As you know, boosting now in this country is similar to now Israel and similar to the UK. It's boosting for almost everybody in this regard. And because we have that capacity, we don't have to triage. I'm fine with that. And of course, the other thing that has changed is the mix and match. So that is permissive. What we tell patients, if you're on a Moderna, you should now get boosted with Moderna. That's available. Remember, that boost is half now the original dose. Get boosted with Pfizer if you can stay on that train. That's the same dose. J&J turns out probably should have always been a 2-dose series. So you can use anything after a J&J for a boost. Another J&J, a Moderna full dose, or a full dose Pfizer. What about requirements? I know this is talked about a lot, and I'm a big vaccine believer. But you know, in this country, there is the religious exemption. There are medical exemptions. It's rare to have a medical exemption for the COVID-19 vaccine, but yes, you can have certain idiopathic allergies. For pregnancy, many people use what we call deferral. The pregnant woman just is too afraid or that something's going to happen and she wants to wait till after. Then how do we document? How do we enforce? And what about prior infection, which we know does give immunity, and probably immunity is as good as vaccine, although the duration of both we don't know. This is an issue ongoing here, in terms of this nature. We see it back and forth talked about. And again, CDC just released their statement today, updated statement on vaccination in people with prior COVID in terms of this. Again, they have not changed their with this document, much more documentation, but they still are a believer that regardless whether you had COVID or not, they are still pushing vaccination in terms of that, and that's kind of the clinic's approach as well. But again, there's a lot of data to question that in terms of this for everybody. Here at the clinic, we've done a couple studies in our own healthcare workers to kind of look at these issues. This was done by my colleague Nabin Shrestha, a very nice study. Remember, these are our employees, so we have documentation of vaccination and we have access to testing all along. And so a positive test was a positive PCR in our lab. This, you can see how we define previously infected, not previously infected, starting when we gave vaccines in December. And the bottom line on those curves you can see is that if you were not previously infected and unvaccinated, that top curve, you had the highest risk of getting COVID over that study period. But you can see the previously infected vaccinated, no difference in subsequent COVID from those who had documented infection and not vaccinated. Again, these are relatively healthy people. These are people where we define infection by a positive PCR, not self-report. But again, interesting data. The bin just extended this data now through the Delta period, and you can see on the top curve again, no vaccine, no prior COVID, still the highest risk, no surprise. But you can see on the other three curves, no prior COVID and vaccinated is about the same as prior COVID and unvaccinated. And the lowest risk, although not significant, were those that had prior COVID and vaccinated. So I like to say there's something in this for everybody in terms of, this does help the people that want to get vaccinated if they had prior COVID, but again, does support the fact that obviously immunity does exist for both vaccine and natural immunity. We just don't know the duration. I'll skip these slides in terms of this. I just want to also point out the White House is obviously pushing vaccine requirement to try to get over the hump for herd immunity. They're using safety for the unvaccinated, the people don't respond, workplace safety for first responders and teachers, and then of course the economy in terms of this. And we've seen many businesses kind of line up behind this. I will tell you, we do work with United Airlines. There are exemptions to their policy in terms of this. So the people that are getting fired are the ones without exemptions who refuse vaccine in terms of here. I think this also has had an effect on us. We've had compassion fatigue. We are tired of treating vaccine preventable disease. But I was reminded, and I like this quote from Rich Lesser, just because we're experiencing the same pandemic doesn't mean we're having the same experience. So many of us have been able to retreat in our homes with a lot of space and things of this nature, not crowded multi-generational homes where we're frontline workers. So I do think this is important. I do feel very privileged in terms of my position and understand that not everyone has had the same experiences. And I think that's part of the empathy that we all have as clinicians. A few things on testing. My recommendations are all of you should have the Binax in your house. You can pick these up from your library. Why, especially if you've got small kids that aren't vaccinated in your home. Many of us over the past 18 months have woken up and said, oh my God, I've got a little headache. Do I have the sniffles? Is it COVID or not? And although the Binax is really made for symptomatic, not asymptomatic testing, this 15-minute test at home can take the air out of the balloon, so to speak, especially for the children. These tests are free and available at your libraries. They also, if you're traveling, you can use these and online. A person will watch you do it, and then you can upload your QR code to get your boarding passes. So these are things that I've advocated for my patients and everything else to have at home with kids, because if that kid wakes up with a little snotty nose, the mom just might want to know before sending to daycare, is it COVID? Is it not COVID? It's not 100%, but at least it does something as opposed to trying to get hold of your pediatrician and get a PCR test. The other thing to reminder is there's more than COVID out there. I'm probably coming over a little rhino from my grandson. There was a lot of RSV in September. We do anticipate we're going to see flu this year. So testing is going to be more than just COVID. we will have the 4-in-1, similar to how we do with peds, RSV, flu, A and B. It's going to be RSV, flu A and B, and COVID. So this will be important, I think, as we move forward into cold and flu season. You know, and I don't want to get militaristic, but for my UK colleagues, we all know about the red poppies in Flanders, you know, memorialized in John McCrae's poem. You know, to my knowledge, we don't have a red poppy for COVID-19, and, you know, we don't have an AIDS memorial flag. I do think this is something, you know, there's no one that I know that has not been affected directly or indirectly. It reminds me a little bit of HIV, but HIV on steroids in terms of the amount of people affected. So I think this is an important lacune. And our learners, I know, are also interested in this type of situation. Finally, forecasting. I'm not good at this. You know, we'll define accepting COVID as the Kubler-Ross model of the 5 stages of grief. So I think we'll probably get to herd immunity. The problem with the R naught gets higher, the higher the herd immunity you have. And so with Delta, that probably means we need to get to about 90%. The pathogen will probably also evolve to become less lethal as other as other SARS common colds have done. I doubt it's going to disappear like SARS-CoV-1 because it's got an animal reservoir and we yet don't know the intermediate reservoir. And humans may become more resistant, but that's not the way we ever want to go. So I do think it's going to hopefully evolve into the other annoying childhood or common cold type of infections as we move along. But it doesn't exclude that some monster variant will occur. And as you can see now, it's always thought that the pandemic waves go up like an elevator and down like an escalator. And so I think we are moving down. It isn't moving as fast as we'd like to see it, but the forecasting is, if nothing else changes in terms of vaccination, in terms of transmissibility, that it should hopefully be a more white Christmas, so to speak, in terms of census, mortality, and morbidity. And with that, I'm going to end. I mean, I was fortunate to have a grandson during COVID, baby William. So that was my Prozac. And it reminds us all, I think, you know, there are things that matter. There are things we can control. And hopefully we're all going to focus on the middle part. So with that, I'm sorry to go over and I'll stand down and just thank you for the opportunity.
Steve, that was fantastic. Thank you so much, Dr. Gordon, and loved the graphics and loved the cricket piece and the poppies and everything. Just great. Thank you so much for the session. And you did not go where we started late, so this is fair. I don't see, Vikram, I think you had a question. If you want to ask that before you get ready to start your session.
Yes, Dr. Gordon, this is just a common sense question. People come to me and, you know, a lot of people do not want the vaccine. They come up with all kinds of excuses for me to write a medical excuse for them. They say they have autoimmune diseases like Hashimoto's or diabetes, and I think it should be all the more they should get it. Is there any good reason we can give a person not to have a vaccine other than an allergy to the vaccine? And if they've never had a vaccine, how do we know they're allergic to it or not? Because they're different vaccines, right? The mRNA is so different from the other vaccines, right? So if you could help me out there.
No, I think it's a great question. But as you know now, this is probably the most studied vaccine in recent history, both pre and post. So we've given 400 million injections in this country alone. The safety profile continues to be written in terms of this. So the biggest is the reactogenicity. The anaphylaxis is usually there's a history there, but you're watched. So I really do think, you know, is that the safety profile is good. The myocarditis is usually mRNA in younger people, the younger men. The J&J, the thrombosis and thrombocytopenia is usually, again, going to be, you know, women less than 50 in terms of this, but there's a variety of vaccines. I tried now to also say, if you don't do it for yourself, do it for your others, the people in your household or others. And sometimes I wonder where the patriotism has gone in this country. You know, when I look at the great world, you know, I mean, look at it. When we look at around the world on things galvanized for other patriotism, that it's not always about me. We get back to the JFK, not ask what you can do for, you know, your country can do. What can we do for others? And so I've tried everything. I must admit, in the hospital now, I'm very much, I don't let it go. I mean, I do have the dialogue. I'm batting this week probably about 400. You know, so it's usually for me a 3-day process, but there are some people that are not going to listen, so to speak. But it's a great question.
Yeah, and along those lines, there's been some comments in an article, I think in Washington Post or The Atlantic, where people are wondering if when the next pandemic hits, we got the vaccines and clearly we can turn them around very quickly. Other than that, are we less prepared than what we were for this pandemic because of all the partisanship and the skewering of the public health officials and, how fragmented our response has been? And if you think that's true, instead of boiling the ocean, is there something that we can do here in Cleveland so that at least we reach out to the community and start preparing for the next one? Would love to know what you think.
No, Neil, I think you're on. And I think the other thing is, this has been an awakening to me, not just about the vaccine, but you can talk about masking, but you can talk about other things in terms of what I call misinformation. And I think we need to learn is we need to learn messaging better. I need to learn about TikTok. I need to learn about effective messaging, because what I would take is, okay, this is common sense. But as you said, if CDC has lost its luster, it runs downhill. Then my society loses luster. Then me as a white coat loses luster, because I'm just accused of just making money off things. So I do think we need to, as opposed to disengage, re-engage now and find out what effective messaging works. And don't let, sometimes it's easier to walk away, and I think this also is apathy in government. It matters. Vote. I mean, I don't care what your politics are, get engaged, right? Have those dialogues. What happened to the time where you can believe something strongly? I can, but I'll sit down and I'll say, Neil, I believe strongly, but I'm willing to listen. And I'm not going to say I'm going to change my mind, but I'm going to change my mind, as opposed to coming to the table, not listening at all. So I don't have those answers, but I'm hoping your learner medical students are going to, be effective. Communication now is a competency for all of our providers.
Yeah, totally. I mean, I think seems like getting advocacy and activism into the curriculum. There is a pathway at CASE that they're looking at. So maybe there'll be a group of students who will get trained in that. Just anecdotally, when I have a student in clinic and I have someone who is hesitant, this is perfect. My students are so well trained in all the common questions. I say, you know what? I'll see the next 2 people. You talk to the patient. Most times, one, it's near peer, right? This is not the authority figure saying something. This is a student. And their ability to communicate is so different than ours. They are usually able, so they are probably batting 500. So, well, let's take it on. That might be a great model, is, having health navigators and educators, someone else, not so much the authority person. And that's really helps. Great. Thank you. Thank you, Steve, for taking the time. And please post any questions you have in the chat and we will try and address that. Steve, I don't know, will you be able to hang around till 4 or?
I've got to go upstairs, Neil. There's I got a round, so
okay, no worries.
Yeah, I'll be happy to address them. If you send it to me, I'll do what I can.
Alex, if you, and just send, okay, thank you so much.
Okay.
So now we're going to turn it over to Dr. Kumar, who you know very well. Dr. Kumar is Chief of Endocrinology at Fairview and Chief of Medicine at Elyria Medical Center. And he's going to talk about inhaled insulin and Afrezza. And I'm very interested in this because the last I heard about inhaled insulin, the first was the Exubra, which went down the drain. And then Afrezza came out and there were a lot of concerns. So I'm very interested to see what your take on this is. So take it away, Dr. Kumar.
Thank you, Dr. Mehta. So I'm going to start talking on Ready, Set, Inhale, which is Afrezza. It's the only inhaled insulin at this time. As Dr. Mehta rightly mentioned, there was another insulin, Exubra, many years ago, 7-8 years ago, which was taken off the market, not for side effects, it just didn't take off. So just to clarify that. So let's talk about Afrezza. It is a insulin, it's a human insulin. So it is the regular human insulin inhaled powder. I hope you can see my slides. So we'll start off with the safety. And the important safety information is it is used as a rapid acting insulin to improve glycemic control. Limitations in type 1, you must use it to long acting insulin because this is a short acting insulin. It's a super short acting insulin. Of course, the risk there is of bronchospasm in people with chronic lung disease, COPD, asthma. So the contraindications are COPD, asthma, and chronic lung disease. Before initiating Afrezza, it's good to perform a full exam and do a spirometry with an FEV1 to make sure that it's not greatly reduced, or at least to get a baseline on. Afrezza can cause hypoglycemia, and of course, that's in all insulins. Next slide. So we are looking at this nice slide, which kind of tells you the history of cars and history of insulin. So it's been about 100 years. And you can see the car started off with a gas-powered wagon in the 1920s. And at that time, used to have reusable insulin syringes. And then we went to the automobile in the 50s and the injectable syringes. And then the dial-up injectable pen came in the 80s. And then we have now come to hybrid cars and the EVs, which technology has advanced, and we came to the pumps. And where does this go next? It goes to the next step, which we should do better with the insulins, including inhaled insulin. We are going to go through the unmet clinical needs, what makes Afrezza different, control in type 1s, control in type 2s, adverse reaction, and dosing and titrations, because everything is a little bit different compared to regular insulins. Unmet clinical needs, as you can see here, although we might feel that in the last 10 years, we've got a bonanza of medications to help us with diabetes. I mean, there used to be, I remember, only glipizide and NPH and R back in 1998 and before. And then metformin came in 98 to the US, and then the others came one after another. We have so many, it's great. So the glycemic control has actually not improved. The average A1C, which has actually increased from 2010, 2012 to 2016, 18 from 7.8 to 8.4, and the majority are not at goal still. This is a CGM. So when you look at insulins, you cannot just do finger sticks. CGMs are now, they're a class apart. It's like another dimension. You see the glucose is almost minute by minute, day and night, all the time. And you can tell when the glucose goes down and up, and it's not just an average glucose over the last, or a point of care glucose. So you see these people are in range, and they may not be in range. They may go up and breakfast, down at lunch, and up after dinner. And this is what is important to know. And the key now is not just looking at A1Cs, but it's the time in range in the glucose. So you see the TIR, which is time in range, and that goes up. So every time the TIR goes up by 10%, there's a decrease in A1C by 0.8%. But time in range is important. You don't want hypoglycemias, as the Accord trial said. They had to pull off, intense control because of hypoglycemias. It was nothing else. So going to the next slide, injectable insulin has some limitations, and it has lipodystrophy. There are people who've used it for a long, long time. Type 1s will get bumps and lumps on their skin where they've used it too much. There's injection burden. I wonder how many of us who are non-diabetics have tried taking a shot, just a hypothetical shot 4 times a day, poking your finger 4 times a day. It's a burden. It's a burden of disease. You can't live like this all your life. It's hard to imagine. And there's no Saturdays, no Sundays, no weekends. There's no time off. So there's a injection burden. There's a needle anxiety. And then there are missed doses, and missed doses sometimes because they just want to take the shot. Hypoglycemia. Hypoglycemia is problematic. And we kind of know from literature that about 2 episodes of symptomatic hypoglycemia may occur in a week, and maybe 1 episode of severe in 1 year, which will cause somebody might need assistance or so. And this causes 1.5 to 2 times more mortality in cardiovascular disease. So the goal would be, how can we minimize hypoglycemia? So let's come to Afrezza. What makes Afrezza different? Understanding the pharmacology of this novel ultra rapid acting insulin, and what you see here is the device which we inhale that insulin. The ultra rapid acting insulin on the top, we'll show it in purple, goes through the pulmonary delivery to the blood in less than a minute. It's very fast. It's a monomer. It goes straight in, compared to the subcutaneous, which is a little more aggregated, and the long acting, which are hexamers and dihexamers and multihexamers, which are slow release for the whole 24 hours, and now we even have 36 hours insulins. Pharmacodynamics. As you see here, on the right is the subcutaneous delivery, and time to measurable effect is 17 to 30 minutes, whereas in pulmonary delivery, you see it's almost like circulating endogenous insulin. And you see, so pulmonary delivery, when you give it, it's very fast, very quick, lasts less, and doesn't have a tail end in staying longer. Circulating insulin in healthy individuals. You measure the insulin sensitivity in an oral glucose administration, and this is what you see. It goes up, it peaks up, and it comes down over the next 3 hours, 4 hours at the most. And then you look at Afrezza profile compared to a rapid acting insulin. So you're looking at Lispro, which is Humalog, 8 units, compared to Afrezza, 12 units, which are equivalent doses. And Afrezza is far more rapidly absorbed and acting. And you see it is, the first 30 minutes or so, it's already peaking here, and then it comes down. It doesn't stay too long. Lispro, which we know is a rapid acting insulin compared to the other long actings like regular insulins in the past. So those are good, but they still take time to go up. And I've seen people who will, especially even if in pumps, you inject them with Lispro, the glucose still tends to rise if they've eaten a carb diet in the first hour or so. The insulin is not able to catch up with that glucose peak. So let's look at diabetes control in type 1s. So Afrezza in type 1s, this was an earlier study showing that it was no less than the sub-Q insulin, and that's what this graph shows. Basal with a sub-Q bolus compared to Afrezza with a basal insulin. So it was non-inferior in 20 weeks period. But when you look at the significance of how well it lowers the postprandial glucoses at 60 and 90 minutes, you see Afrezza does a great job within the first hour of cutting out that peak effect of any eaten food or glucose compared to a sub-Q insulin, which still has some peak and it comes down over time. So postprandial glucose is associated with Afrezza versus sub-Q. As you can see, much better, lower postprandial peaks with breakfast, lunch, and dinner compared to sub-Q. The sub-Q is in the orange, and Afrezza, which is inhaled insulin, is in the purple. And improve time in range, the TIR. This is going to be the buzzword for the next many years now. So TIR, time in range, a lot more with Afrezza on the purple on the right side compared to sub-Q insulins. And people who were non-compliant with Afrezza still equaled the sub-Q insulin doses. Lower rates of postprandial hypoglycemia. So type 1s take a shot, and after a while, they may have a low glucose. Sometimes it peaks up very quickly when the sub-Q insulin doesn't take effect, and then there's too much insulin and you get a low sugar after, or a low glucose after 3-4 hours. As you see here, the hypoglycemic events with the Afrezza are less. The level 1 events, which is less than 70 glucose, and the level 2 events was less than 54.1, were both less. And the level 3 requiring external recovery were also quite less compared to the sub-Q insulin. So this is the advantage you see with the Afrezza, which is inhaled insulin, both having hypoglycemias which are lower in rates and having a quick onset of action. It was also had lower postprandial hypoglycemias in Afrezza versus sub-Q. Another study here showing the late postprandial hypoglycemias. So the sub-Q insulin tends to have a prolonged action later on. And you can see after 2 to 5 hours, there is more hypoglycemia in sub-Q insulin compared to Afrezza after 2 to 5 hours. Of course, I did mention that the type 1s do need a basal insulin to go with the Afrezza. Then you come to type 2s, which this can also be used in type 2s, and you can use with or without basal insulin in type 2s. So proven A1C control in insulin naive patients, so person who has insulin naive, you want to start them on insulin and they are not being controlled with oral agents, you will have a better control. You look at this, there is an improved control of 32% versus 15.3% of A1C less than 7 in Afrezza versus subcu insulin. Also in the bottom, you see the patients on Afrezza had less weight gain compared to orals alone. So this is the real world study also, baseline versus 12 weeks, 9.0 to 7.4 after starting Afrezza. So Afrezza does work. The insulin is effective. The real world, again, time in range, a lot better, 65% time in range versus 42% after 12 weeks of starting Afrezza. Weight gain. You see aspart on the left, which has got a slight weight gain of 0.61, and the biaspart, which is a mixed insulin, of 1.2, even a little more. And Afrezza has almost neutral. There was not much weight gain. You see a minus 0.23. So there are some advantages to using the inhaled insulin. Common adverse effects, as you would expect. You see there is subcu versus Afrezza. Of course, the cough is there, 29% versus 4.9%, and throat irritation, 5%. And if you give an inhaled powder, which is a placebo, compared to Afrezza, there's 19 versus 25% of cough and 3.8 versus 4.4% of throat irritation. But most of these coughs, as we'll see in the next slide, improve over time. 94% of episodes of coughs were just intermittent or single coughs, which are all put in this graph here. And you see the 10% cough in the first week rapidly goes down to a 4% and keeps going down till week 7 or 8, down to less than 2% or almost between 1 to 2%. So there is a continued improvement of cough as patients get used to this way of taking insulin. You should monitor the lung function, of course, and FEV1 is required to do. These are very tiny gadgets. You can have one in the office. You can also have one sent to the patient's home in times of COVID. If they want to start it at home, they just go blow into this device, FEV1 device. It gives them a reading, and you can have that. There is no cutoff here. This is for the doctor's own knowledge to see where the patient is when you start on their Afrezza. Lung function data. Now, of course, you're going to ask me this question, what happens to the lung function when you take an inhaled insulin? And there is a change in FEV1 when you start Afrezza. You're looking at these two graphs of comparator versus Afrezza, and there is a slight decline when patients start on Afrezza. And this decline, as you see on the bottom, is a small 40 ml reduction, which is about almost equal to a 1% decline. There is a usual 1% decline in patients, almost a 1% every year as we age. So there's a 40 ml or 1% decline in total lung capacity. And this decline, clinical trials lasting for 2 years have shown that these were non-progressive. So FEV1 rate of decline per year is 25 to 40 mLs per year in a person normally. So this is like 1 year less almost when you start Afrezza. Dosing and titration. Now dosing is a little bit different in Afrezza. The typical dosing is mealtime, and most patients need about 12 to 24 units. The dosing consideration, as you see in the second line down here, shows that the clinical trials have shown it may take about 1.5 times the amount of Afrezza. So if somebody's on 8 units of Lispro, you probably need about 12 units of Afrezza for the meal. And effective dosing can be changed. You can add on, you can increase it, decreases as the patient wishes, as you wish, especially looking at the glucoses. So example of prandial dosing, if the patient is using about 5 to 8 units, you start Afrezza at 8 and you can titrate up to 8 to 12. And that's how it goes up, 1.5 times to almost 2 times the dose. We can go with some patient scenarios. If we have some time, I'll make it brief. You can have this is a college student of type 1 diabetes who has an A1C of 8.9% and uses injectable mealtime insulin and having difficulty controlling the glucose. She's going to college. She's not able to maintain it. What can we do? Can we help her with taking inhaled insulin while she's at class, while she's going she's going out to eat somewhere, or she's just studying, and she can carry this with her. You can also have a patient on an insulin pump who may say, I'm still having exacerbations after the insulin pump, and even though I take my bolus, it doesn't quite come down. And with the basal going with the insulin pump, you can add on Afrezza each time he wants. Also, of course, he also complains of dizziness, shakiness, and maybe he's having hypoglycemias, and hypoglycemias are reduced a lot when you take inhaled insulin. Somebody who's new to insulin therapy, glucose is high. You can add Afrezza, especially if they have obese, they are gaining weight, they don't want to gain any more weight. Or some people are afraid, I'm not going to take insulin because it makes me gain weight. So that's another kind of a patient. And the third would be a person who is a worker, factory worker, who is all into stuff like he's working, he's greased hands, he can't take a shot, and he can take inhaled insulin if he's got a CGM on, and he can see his continuous monitor all the time. So those are the different scenarios, and I'll go over the safety information once again just before stopping this. So Afrezza is again not to be used with lung disease, COPD or asthma. Asthma and in type 1s, you should use it with a long-acting insulin always, and not just a short-acting. And if you have any episodes of hypoglycemia, obviously don't give more Afrezza. Warnings: bronchospasm. If there's a change in insulin regimen, you should look out for glucoses. There may be hypoglycemia. There may be a decline in pulmonary function about 40 mLs, which is about what would decline in a year. And again, safety information: chances of lung cancer not sustained with there's no correlation, but there were 2 cases of lung cancer who were exposed to Afrezza, but no additional cases. DKA can happen, but again, DKA can happen with all kinds of insulins. Type 1s should definitely be on a basal insulin. Hypersensitivity can happen. Hypokalemia, of course, true with every insulin, can happen here too. And fluid retention and heart failure, again, especially with people on other products like TZDs, can happen. So with this, I would say, wrap it up saying Afrezza is a fast in, fast out insulin. It's like a race car. It enters the blood in less than a minute and measurable effects in about 12 minutes. Peak effect in about 35 to 45 minutes, which is quite fast. And it's out about 1.5 to 3 hours at the most. So a lot of people who take a big meal may need a second shot of Afrezza after an hour if the glucose is still up. Afrezza is one-of-a-kind insulin, increased time in range on the continuous glucose monitors, lower incidences of hypoglycemias, and provides mealtime spontaneity. You eat 5 times you want to eat, you can take inhales 5 times if you don't want to take 5 shots a day. You take a bigger meal, you take a bigger dose. You take a smaller meal, take a smaller dose. Very convenient. So I will end this talk with the Ready, Set, Inhale Afrezza. If any questions?
Thanks so much, Dr. Kumar. This was terrific. As always, I learn a lot every time I listen to you. I remember the last year's presentation, and it changes your practice. So thank you. I'm waiting for people to post questions, but in the meantime, I was thinking about this. I have not used this at all. And question is, do you always have people on a CGM when you use this? And secondly, what are the cost issues and formulary issues of trying to get people on this plus a CGM? Is it difficult, or is it formulary on most, or what's been your experience?
So the Afrezza has a special, they have set up a special pharmacy to help out. It's called UBC, and you can mail it to the UBC pharmacy. And if you send the patient notes, they help to get people through. I have had a lot of patients who have been able to get Afrezza with the help of, I don't have to do all the paperwork then of getting it approved. I've had people with all kinds of insurance who have been approved with Afrezza. Of course, there are so many carve-outs now, it's hard to tell unless you try. You do not need a CGM for this. The CGM is obviously a plus. The continuous glucose monitors like the Dexcoms and the other ones and the Libres, and there are a few more, can help a lot, because now you can dose it really, really well. If you have a continuous monitor, which is now approved in Medicare patients who take 3 shots of insulin a day, and in COVID times, even that was relaxed. So you can easily get people at least on Medicare, and type 1s have always been easier to get in commercials also, but sometimes type 2s also allowed under Medicare, you can get a CGM. And that helps to dose it multiple times. If you do not, I had a person on a pump who would look at his CGM, eat breakfast. As the sugar starts to go up to 140s, he would take inhaled Afrezza, and then he'll wait and see. In the next hour, it comes down fine. It doesn't come down, he takes another, inhale of Afrezza. He kept the glucose never above 140 with that, and never dropped below 70. He kept it really tight. So I had another patient with this who was a renal patient. These are notorious for having ups and downs. And this guy was having ambulance every 2 weeks coming to his house with a glucose of 20s and 30s, and then up to 400s. We put him on Afrezza. I didn't see him for 3 months. So what happened? Oh, doc, you cured me. I don't have to see you anymore. So, but you can use that without, just like a sub-Q shot. You can do a finger poke, and you can take the inhaled insulin, and then you can dose it judge, of how you respond to it, of course. So
great. Thanks. We have a question from the audience, that is there any data about how much you inhale versus the lung capacity, or is it the same regardless of how much you use?
With the lung capacity, the inhaled insulin, it comes as a little pellet. It has 4 units, 8 units, and 12 units, and those do not change with the lung capacity at all. If lung capacity diminishes a lot, it's the doctor's burden to tell the patient, hey, come off it. But usually the patients I have had on have been doing pretty good on this. The lung capacity is not the concern. People can go up to 24 units, 48 units. It is almost 1.5 to 2 times the regular insulin dose.
Okay. And as far as smokers go, is there a total contraindication, or is it relative?
Well, it's a total for now. It's a total because that is the what was approved. So we like to stick to not giving smokers the inhaled insulin now.
And that's if ever smoked, or current smoke, ever smoked. Current smokers. Okay. All right. Yeah. I think I remember one of the issues with Exubera was, I think they had more people in the trial with lung cancer compared to Afrezza. And I didn't follow that too much because it got pulled. But I think that's what you hear from people a lot. So
it was not pulled. It was pulled by the company because it just didn't work out for them.
Got it. Great. Any other questions? I think otherwise we'll turn it over back to you, Vic, to introduce Dr. Thomas.
Okay. Thank you, Neil. Dr. Thomas, glad to have you here. So our next speaker is Dr. George Thomas. He's at staff and a director for the Center of Blood Pressure Disorders, Cleveland Clinic, Glickman Urological and Kidney Institute, Nephrology and Hypertension at Cleveland. Welcome, Dr. Thomas. So Dr. Thomas did his medical schooling in India and has been in the US for many years. He did his MPH at Johns Hopkins and then went to St. Elizabeth's Medical School in Tufts in Boston, and then did his fellowship in nephrology at the Cleveland Clinic here. He is, as I said, he's the chief of the hypertension clinic at Cleveland Clinic. He has several boards. He's boarded in internal medicine, in nephrology, and has the American Society of Hypertension boards also. He has many memberships, including American College of Physicians and nephrology and the National Kidney Associations and hypertension and so many more. Of note is that he's in the editorial board of the Clinical Journal of American Society of Nephrology, and he's a manuscript reviewer for several magazines, including Clinical Nephrology, Clinical Journal of American Society of Nephrology, Cleveland Clinic Journal of Medicine, and Gulf Hyper, and has been to many conferences. including the Gulf Hypertension conferences in Dubai, in UAE. Several times over several years, he's conducted those. He's also on several national committees and is also on the Committee for Nephrology Fellowship Interview Committee, has numerous awards and honors, numerous teaching activities I cannot mention here, and many academic appointments and membership to professional societies. So having said that, I welcome Dr. George Thomas, and he will be talking to us today on device-based therapies for hypertension. Where are we at? Welcome.
Thank you. Thank you so much, Vikram. And thank you, Neil and Vinny as well, for the opportunity to present today. I hope everybody can see my slides and hear me okay. Good afternoon, everyone. So just changing gears just a little bit and discuss a few things about hypertension now. Hypertension, as we all know, is something that all of us have to deal with at some point or the other, no matter what specialty we are in. We all have to deal with patients who have hypertension. And hypertension is such a vast topic, and I decided that in the next 30 minutes or so, we would focus on device-based therapies. The reason being, these are relatively new, but in the next few years, these are probably going to gain more prominence, and we're going to hear more about these therapies to treat hypertension. Keep in mind that these are not available for clinical use at this time, but certainly in the next few years, we're going to hear more about these. So my objectives today are to understand the concept and physiological rationale of device-based therapies, to summarize some of the main trials of device-based therapies that have been done, and what are the future directions. So just as a snapshot table here, what are the blood pressure goals now? So I think everybody's familiar with this. You know, if you go back to JNC7, we were dealing with blood pressure goals of less than 140/90, and I've listed the general population here, what the goals are. So JNC7, going back to 2003, it was less than 140/90. And for the longest time, that was where we were aiming our blood pressure goals to be at. Come JNC8, or more rightly JNC8 panel, they relaxed the goals just a little bit, especially for the elderly. But then came the SPRINT trial, and everything kind of changed since 2017. We are tightening our blood pressure controls much more. And at this point, really, we are aiming for much more aggressive blood pressure control to less than 130/80. And I will mention here, this is not for the general population, but our most recent CKD guidelines in chronic kidney disease. The KDIGO guidelines actually suggest or recommend a goal of less than 120 systolic in chronic kidney disease patients. So you can see how the pendulum has really shifted from the less than 140/90 to really become more aggressive in blood pressure control. So what are the basics of hypertension? So just, again, like a snapshot here, we know the basics are measurement. You have office blood pressures and out-of-office blood pressures. Out-of-office blood pressures, you either ask the patient to check it at home, or you do 24-hour ambulatory blood pressure monitoring. You talk about all these lifestyle modifications, ranging from low salt diet, weight management, exercise, get enough sleep, low alcohol use, and the medications. And as you all know, the medications are A, C, or D are first line, ACE or ARBs, calcium channel blockers, diuretics. B is not first line, but beta blockers can and should be used if there are compelling indications. And then certainly if these don't work, there's data now, especially from the pathway trial and in guidelines as well, that mineralocorticoid receptor antagonists like spironolactone should be added on. And then if these don't work, you keep adding on agents from other classes. So this should be very simple, right? You have your lifestyle modifications, you have your medications, you have your methods of blood pressure measurement. How hard can this be? So it turns out these are some of the challenges we face, right? And these are things that all of us as treating physicians have sort of faced with our patients. One is adherence. This is something that we don't pay as much attention to, but we should, because studies have shown that adherence or non-adherence can range from 30 to 50%. And these are studies which have looked at actual drug levels in the blood and the urine. And up to 50% of patients may not be taking everything that they're supposed to take. And some of the reasons could be polypharmacy, as again, studies have shown that as the number of medications goes up, certainly the non-adherence goes up as well. And these are things that we may have heard from our patients. I don't want another medication, or the one I'm on isn't working, or I'm allergic to medications. So that's multi-drug intolerant hypertension. And over and above resistant hypertension, which is defined as being on 3 drugs and not controlled, there's this entity called refractory hypertension. That is uncontrolled blood pressure with at least 5 medications, including a diuretic and spironolactone. So these are some of the challenges we face with medications and blood pressure control. So the question is, are there other possible options? Okay, we talked about the challenges with medications, and this is where device-based therapy can possibly come in. So these are some of the landmark trials in device-based therapies in the last decade or so. And I just listed a whole slew of them, and we won't be discussing each and every one of these, but I'll go through some of the main ones that have been done. Okay, so starting clockwise, I would say the first thing that I would discuss or just mention is the ROX coupler device. Again, just keep in mind, these are all investigational devices. None of them are FDA approved for clinical use. So we don't have these at this point other than in research trials in the US. So the ROX coupler device was an interesting concept where an anastomosis was created between the iliac artery and the iliac vein. And there was a device that would be placed as an anastomotic channel, and you divert the blood from the arterial system into the high capacitance venous system, and you decrease the systemic vascular resistance. So that was the idea behind this ROX coupler device. Turns out it did reduce blood pressure, but there were a lot of problems with venous stenosis. So a lot of complications vascular-wise, and the company essentially shut that down. Then we come to this entity or this device called the baroreceptor activation therapy. So as you can see here, that is an electrode that goes on the carotid wall. It's sutured onto the carotid wall. It's attached to this generator, which sort of delivers this electrical stimulation. So as you recall, if the baroreceptors are stimulated, it sends signals to decrease the sympathetic outflow. So essentially, baroreceptor stimulation and decreased sympathetic outflow leads to decreased blood pressure. So this is electrical stimulation with this device implanted in the carotid sinus. And this can be sort of turned on or off. It's a programmable device that can be controlled with remotely as well. The problem with this, as you can imagine, is there could be surgical complications, there could be vascular injuries, there could be nerve injuries. So again, this device at this point, it's unclear where this will go. Very similar concept, and this was called baroreceptor amplification therapy. So instead of activation therapy, it's amplification therapy. So instead of electrical stimulation, as in this one, here there's a mechanical stimulation. So you implant a device. This is not surgical, as in the other one. This is endovascularly implanted. And this sort of a device, stent-like device, it stays in the carotid sinus. And the idea is that it increases the relative radius of the carotid sinus, and it increases sort of the strain in the wall, and that stimulates the baroreceptors. Again, the idea being the baroreceptors are stimulated, and you decrease your sympathetic outflow, and you thereby reduce the blood pressure. So this was certainly lesser complications, so to speak, compared to the other one. But and there is a big ongoing trial at this point called the CON2 trial. It is unclear what the results will be and where this device will go in the future. We're waiting for results on that. The last one, and this is the one I'll be talking about most, is called renal denervation. So many of you may have heard about this. This is basically trying to ablate the renal nerves, which are around the kidney artery, and sort of cutting off the sympathetic signaling. And I'll go into more detail about that in the next few slides. So before we go into details, I just want to pause and sort of look back at what antihypertensive therapy has been or was in the past, like pre-1950s. We didn't have medications at that time, right? What we have right now, we talk about the A, C, D, B, MRAs, none of that was available. So what did they use back then? They used a bunch of sedatives. They induced fevers, and they did all kinds of trials with diet and rice diet. But there's one little thing here called sympathectomy, right? This surgical sympathectomy. So this was reserved for people who had really malignant hypertension, really bad blood pressures, really severe end organ damage. And as the name suggests, it's basically cutting off the sympathetic trunk to reduce the blood pressure. So this was a report from 1948, which shows it describes the medical and surgical treatment of hypertension. And they kind of describe what sympathectomy was. And they did get a lot of good results with hypertension control. The blood pressure, the patients who had it had a pretty significant drop in blood pressures. But as you can imagine, with cutting off the sympathetic trunk, there was a lot of side effects as well. Orthostatic hypotension, erectile dysfunction, lightheadedness, dizziness. So it came with a lot of side effects. Of course, with the advent of medications, nobody really paid more attention to that. We essentially have come full circle in a way now that we have medications, but medications don't seem to be the only things that may help hypertension. We're looking back at what else can be done and sort of trying to finesse this approach of sympathectomy and coming to this concept of the sympathorenal axis. So this essentially is looking at the crosstalk between the central nervous system and the kidneys in the context of sympathetic hyperactivation. So that's the vasomotor center right there that you see. It's in a basal state of inhibition. And there are these afferent nerves that signal, or afferent activity that goes up to the brain when there is stretch or ischemia in the kidneys, or any aberrant activity for that matter. And that leads to disinhibition of the vasomotor center and leads to this amplified central sympathetic outflow. When there's amplified central sympathetic outflow, as you can imagine, there's vasoconstriction, there's increased contractility, there's renin-angiotensin-aldosterone activation, and there's all the badness that happens in the body is the after effect of this activation. So essentially this afferent and efferent sympathetic signaling between the kidneys and the nerves are a good target to sort of cut off. So you disrupt these renal nerves. The idea behind this is disrupt the renal nerves and break the cycle. So you reduce both the efferent and afferent effects and reduce the blood pressure. So how do we do that? Instead of this radical sympathectomy that was done in the past, can we do a more nuanced approach where the renal nerves, which are found around the renal arteries, can they be targeted more specifically? So it turns out that a catheter-based approach can be done. So it goes into the renal arteries, and this is a cross-section of the artery. And this catheter can be sort of threaded into the renal artery, and you apply radiofrequency energy onto the vessel wall, and you essentially ablate or burn off the renal nerves that are in the adventitial layer. And the idea is you decrease that sympathetic signaling between the kidney and the brain, and in the process, decrease the blood pressure. So does it actually work? Does it do what it's supposed to do? Does it reduce the sympathetic tone? Now, MSNA, or muscle sympathetic nerve activity, is a technique to measure sympathetic activity, essentially. So it looks at the peroneal nerves and the sympathetic firing of the peroneal nerves. It's a very sophisticated technique and a very laborious one. It's only available in a research setting. So this is a report in a 59-year-old that was published who had renal denervation done, who was on multiple antihypertensive medications, and what happened to this patient who got renal denervation. So this is a baseline, and this is the muscle sympathetic nerve activity bursts, 56 bursts per minute, and his blood pressure was in the 160s. A month after denervation, his blood pressure comes down, and his sympathetic activity also comes down. And about a year later, his blood pressure is pretty close to normal at this point, and you can see the sympathetic signaling is also down. So essentially, there's some proof of principle that this denervation does what it's supposed to do, essentially to reduce the sympathetic tone, and thereby it decreases the blood pressure. So this is the first generation device that was used for denervation. As you can see, this catheter with the single electrode that is threaded onto the kidney arteries, and it goes into the kidney arteries, and you apply it against the kidney artery, and you start applying this radiofrequency energy ablation in a distal to proximal manner, and you try to burn off the renal nerves in this way. So again, looking at the histology, this is the vessel lumen, and this is where the energy is applied. And these are the renal nerves in the adventitial layer, and this is what you're trying to target. So what did the studies show? Now, this was a big Simplicity Hypertension 3 study using this single electrode device. Now, you may think, what happened to Simplicity Hypertension 1 and 2? Why am I just talking about Hypertension 3? Now, Hypertension 1 and 2 were positive studies. They were done in Europe. They showed significant decrease in blood pressures, really positive results. So it was like this was a new thing for hypertension management. However, 1 and 2, Simplicity Hypertension 1 and 2 were non-randomized. And as we heard before, really randomized trials are what we need to sort of look at the efficacy of a therapy. So Simplicity Hypertension 3 was designed as a randomized trial. It was the largest trial using this device, and it was done in the US. The idea was this would be sort of a slam dunk trial, and it would show positive results, and that would go on to FDA approval. So that was the goal of this study, basically the largest study, randomized trial, get FDA approval, and this was going to be the next big thing for hypertension management. So as far as randomization, I'll quickly mention, so there was a denervation group and a sham group. So all patients in the study would get a renal angiogram. They all go on the table and they all get a renal angiogram. They all have an invasive procedure done, essentially the renal angiogram. And then on the table, after the renal angiogram is done and their sort of artery anatomy is looked at, is it conducive to procedure? Is it conducive as far as the size and the branches and everything? And then they get randomized on the table to either get denervated or a sham group. Now, the denervation group, of course, gets the denervation. What happens to the sham group? The sham group, essentially, they just lie on the table. They get, they have these earmuffs and eyepieces, so they don't know what's going on. So they're kind of blinded to the procedure. So the idea was that they would not know whether they actually got denervation or not. So that essentially had, so we had this randomization into the denervation and the sham group. So what did the study show? So this is the denervation group. Certainly there was a change in blood pressure. From baseline, there was a 14 millimeter systolic drop in blood pressure. But look at the sham group. They also dropped their blood pressures by about 11 points. So the idea was that this procedure would have at least a 5 millimeter difference between the two groups, this denervation versus sham. There was a superiority margin of 5 millimeters. Unfortunately, the study did not meet that. The planned superiority margin of 5 millimeters was not achieved. So this was a negative trial. And as you can imagine, all hell broke loose after that. So not just in the medical literature, but even in the lay press, the Wall Street Journal, Reuters, Bloomberg. So Medtronic misses its blood pressure device goal, because this was supposed to be a $1 billion industry and the next big thing for hypertension. Unfortunately, everything seemed to go to hell with this study. And interestingly enough, this is some data that was pulled from PubMed. And as you can see, in the past, when Hypertension 1 and 2, which were positive studies, were published, the interest kind of went significantly high. And after Hypertension 3 came out, the interest in renal denervation really went low. So this sounded like it was a death knell for renal denervation. Sounded promising, had sort of the pathophysiology seemed sound. The earlier studies seemed promising. They had animal studies, they had initial in-man studies, but the randomized trial unfortunately failed. So of course, this was, again, too big to fail, as we say. So the questions were back to the drawing board, what happened? So there was a big sort of discussion among medical folks and in the industry as to what may have happened that led to this negative trial. And a couple of things, again, I'm not going to go through each of these, but a couple of things that were focused on. One was the catheter design itself. So as we saw, it was a single electrode device. You had to go to different spots and ablate. The question is, are we getting enough ablation done? Are we targeting enough renal nerves? And the other thing was the medications. How were the medications managed? So the medications really, there were a lot of changes made for these patients, both in the denervation group and the sham group. And there was a lot of noise. So it was difficult to tease out what the actual impact of the denervation itself would be, because there were a lot of changes with the medications that were being made in the context of the trial, and it wasn't really standardized. So these were a couple of things in addition to the others that came up. And again, back to the drawing board. And from the perspective of the catheter design, I will mention that in the design of further studies, what they looked at was how the renal nerves were distributed around the renal artery. Now, the initial concept of or thinking was that all the nerves are uniformly distributed along the renal artery. But the current thinking is that, well, it's not uniformly distributed, but these renal nerves may be closer to the vessel in the distal aspect, or where they sort of branch. That may be closer to the wall, so they may be easier to target. So instead of looking more proximally, instead of ablating more proximally, if you ablate more distally, you might get more bang for the buck as far as the number of renal nerves that are targeted. Now, keep in mind, there's no real-time mapping that is done to see how much ablation you got or what the efficacy was as far as ablation. But here you would think that, if you're targeted more distally, you would sort of target more renal nerves to be ablated. So this wasn't kept in mind, or this wasn't something that was considered in the initial few studies with Simplicity. So keeping that in mind, a new device was designed. So instead of that single electrode device, a multi-electrode device was designed, and this device would be targeting renal nerves more distally and even in the branches. So the idea was this may be quicker because, with a single spacing, there's multiple electrodes that target multiple areas for ablation compared to the single electrode device. And we would go more distally, essentially, even into the branches. So this may be more efficacious as far as targeting more nerves. So what did this show? So this multi-electrode radiofrequency ablation was essentially the next series of studies that were done after the negative Simplicity study. So these were called the spiral studies. So there were spiral hypertension on and off studies. Now, one thing I'll mention, Simplicity was done in resistant hypertension, but these spiral studies were not in resistant hypertension. There was actually one group or one study that looked at hypertension off, which is off medications, and hypertension on, which is 1 to 3 medications. So these were standardized. As I mentioned, the medication changes through a lot of noise into that initial Simplicity trial. So here they wanted to standard medication. So essentially the hypertension on folks would have 1 to 3 medications, and the hypertension off study would be off medications. This was to try and figure out whether this even works for hypertension. So that was why they designed it off medications. This was also sham controlled, that everybody would go on the table, get an angiogram, then get denervation or sham. Interestingly, I'll just point this out, medication adherence in spiral hypertension on was about 60%. Now, again, nothing to do with this talk per se, but going back to the issue of adherence. As I mentioned before, adherence is a problem. And this was a study where adherence was actually monitored. They were actually looking at patients and how they took their medications. They were actually getting drug levels. Even in such a study, the adherence was about 60%. So you can imagine that adherence is a problem. Now back to the study, hypertension on, hypertension off, and I just quickly present that in the red bar here. And as you can see, significant drop in blood pressures, both in the office blood pressures and in the 24-hour blood pressures, and significant difference compared to the sham. So essentially the spiral group of studies happen to be positive studies as opposed to the Simplicity Hypertension 3. These were positive trials. Now, those were the multi-electrode devices. Now, another device was designed called the Paradise ultrasound catheter. So the idea behind this was thermal ablation. Now, if you recall, I mentioned that the prior devices, whether it was single electrode or multi-electrode spiral, they were radiofrequency devices. This is an ultrasound device which uses thermal ablation. Again, the idea is that you use ultrasound-based thermal ablation, and there's this water cooling mechanism around it to protect the vessel wall. In theory, this is supposed to provide more ablation. So all these newer devices that do renal denervation, the idea is to target more renal nerves. Because as I mentioned before, there's no way to map this, but you want to target with whatever device you're using, you want to target much more or many more renal nerves than you think the earlier devices could target. So this device was designed in such a way that, at least in theory, it was more complete, more circumferential ablation. So this is thermal ablation as opposed to radiofrequency ablation. So what did this show? So this is called a Paradise study, ultrasound-based nerve ablation. Again, this particular study, Radiance Hypertension Solo, was off medication, so not resistant hypertension, sham controlled. And I put this here, what the results were. Very comparable to the spiral studies, which used multi-electrode radiofrequency ablation. Significant drop in blood pressures, both office and 24-hour, and significant difference between the denervation group and the sham group. Again, a positive study. Now, both the spiral and this Radiance Solo were not in resistant hypertension. So what about resistant hypertension? Are there any new studies in resistant hypertension? So Radiance actually did a study in resistant hypertension. Radiance meaning the thermal ablation, the ultrasound thermal ablation. They did a study in resistant hypertension, which was actually just published this year, earlier this year. So how they did it was they would give all patients a 3-drug combination. So of medications, so that the medications can be standardized. So the medications would come in a single pill. It included amlodipine, it included valsartan or olmesartan, and hydrochlorothiazide. So it came in a single pill. And again, the interesting thing I'll point out here is this study looked at adherence, and it was 82%. So slightly better than the other spiral study, which showed an adherence of 60%. The big difference was this came as a combination pill of 3 medications. Again, getting into the point of polypharmacy and perhaps adherence improving with single pill combinations. So again, besides the point for this particular study, this is how they designed it. And then again, coming on to the denervation versus sham, and the endpoint was measured at 2 months. The reason they measured it at 2 months is, keep in mind, these are patients with resistant hypertension. They wanted to avoid medication changes as much as possible, but do it in a safe way. So they didn't want to take it too long. And this study was with a primary efficacy endpoint at 2 months. So what did they find? So they looked at the primary endpoint as daytime ambulatory blood pressure, significant decrease in blood pressure in the denervation group, and significant difference between the denervation and the sham group. So essentially, after Simplicity 3, which was a negative study, this is the first study in resistant hypertension that ends up being positive. So just to put this all together, if you look at all the studies in renal denervation, going back to the first generation single electrode studies, these are the Simplicity studies. 1 and 2 were positive, but were not randomized. And Hypertension 3 was a randomized study in the US, which was negative. After that, a lot of design changes were made, and we came up with the multi-electrode devices, which were the spiral studies. All of them turned out to be positive. And then ultrasound-based renal denervation, which was the Paradise catheter, which the studies were called the Radiance studies. So Radiance Solo off medication was positive, and Radiance Trio, which was done in resistant hypertension, was also positive. So compared to the earlier Simplicity trial, the recent trials, all in renal denervation, turned out to be positive trials. Now, the next set of devices that are out there are the alcohol infusion. I'm not going to discuss that, but alcohol-based denervation. Basically, they inject alcohol into the renal arteries and again try to ablate the renal nerves. Again, the idea being targeting more renal nerves for ablation. So those are the target studies that may come out in the future. So having said all this, the big question is a procedure worth it? So in this table, this is data from 2003. And as you can see here, this is how much blood pressure drops on average with a standard dose of a blood pressure medication, about 9 millimeters or so, okay, a standard dose of a blood pressure pill. And this is from the spiral hypertension study. You can see the office blood pressure dropping about the same amount, 9 millimeters of mercury. So you're essentially getting the same effect as a medication. Adding on a medication and getting this device therapy seem to have the same sort of efficacy per se. So the big question is, well, the expense and risk of a procedure, is it worth it when the same effect may be gained by simple oral antihypertensive medications? That's a fair question. But on the other side, you're balancing it with patients who experience multi-drug intolerance and they're unable to take their medications. And the real-world experience, as I kept alluding to, adherence can be difficult. Even the spiral hypertension on, when actually med adherence was observed, as we noted, it was only 60%. And then could there be a one-and-done advantage for device-based therapies where you get this therapy and then you're done? Basically, you don't have to take many more medications. Is that an advantage? So those risks and benefits, of course, have to be balanced and thought about. And the other big thing is, what is the individual patient response? Everybody who got, or even in the positive trials, like this is the Radiance Trio with resistant hypertension, you can see the responses are not uniform. It's not that everybody who got denervation had a blood pressure decrease. There were patients who did not respond at all. And there were patients who showed significant response. So how do we identify those patients who are likely to respond? We don't know. We do not yet know how to identify patients who may respond like this group here. We don't know how to identify these patients with certainty, who is likely to benefit. So if we put it all together in summary, what is the efficacy of renal denervation? The effect size is modest. As I mentioned, it's equal to taking a blood pressure pill. But again, risk and benefits have to be balanced as far as, hey, are they able to tolerate medications, or would they benefit from something more or something else? Renal denervation, again, as I mentioned just previously, the responses have been variable. Not everybody responds in the same dramatic way. We need to identify predictors of response. At this point, we don't know that. Could there be a delayed response? Patients who don't initially respond with the denervation, could they respond with time? Is there some delayed factor that you see later on? What are the long-term results? So we know that some of the earlier studies, they have followed patients up to 3 years. And in studies which showed efficacy, like the Simplicity 1 and 2, the long-term results persisted up to 3 years that were published. How about reinnervation? We are denervating these nerves, and do they grow back? So in animal models and in transplant, we know that anatomically these nerves can grow back, but what is the functional significance is unclear. Or could there be what we call a legacy effect that normalizes this hyperinnervation, that there's some kind of reset point where initially they were hyperactive as far as the sympathetic system, and does this device or does this therapy result in some reset of that sympathetic nervous system hyperactivation that leads to a better blood pressure control over time? We don't know that. Now, what about safety? I didn't mention too much about it, but all the studies which showed efficacy, there were no significant safety effects. The big things that come to mind, of course, are, could there be something with the renal artery stenosis? There were no real reports of renal artery stenosis in a significant way that were reported, but at least that was in the short term. But could there be any longer term vascular effects are unclear. What about homeostatic challenge? We know we need the sympathetic system to respond to some homeostatic challenge. For example, there were studies done in sheep that got renal denervation and were subject to blood loss, and they could not really mount a good response to that blood loss. So how that translates into humans, we don't know. So is that an altered compensatory response? We do not know. What about high-risk subgroups? And I can mention diabetes. Most of these studies excluded type 1 diabetes. They excluded uncontrolled type 2 diabetes. They excluded severe chronic kidney disease, especially the GFRs for all of these patients, or in all these studies, had to be above 40 or 45. So at the most, they included CKD stage 3A. And we know that the worse the CKD and the worse the diabetes, we know those are the high-risk subgroups which are, more difficult to control, essentially. So we don't have much data in those subgroups. What about resistant hypertension? As I mentioned, there's not too many studies with resistant hypertension, just Simplicity Hypertension 3, which was a negative study, and the most recent Radiance Hypertension Trio, which was done in resistant hypertension. That's a positive study. But all the other interval studies were done in mild to moderate hypertension or off medications. Having said all this, we may see FDA approval at some point soon. It's unclear. Now, with all the recent positive studies, certainly there may be a point where all the data is submitted to the FDA, and we may see that the FDA could approve it in a certain subset of patients. We don't know which subset yet, and we don't know, again, how to identify patients who may respond. So all this is something that the FDA will likely look at. But I think this is something we will hear about in the near future much more than we know about now, because we thought that renal denervation was dead after Simplicity Hypertension 3, but it seemed to have been making a comeback. So let me summarize with this. Hypertension is complex. One size does not fit all, as we all know with the patients that we see. Medications are safe, they're effective. However, the issue with medications is polypharmacy, tolerability, adherence, especially as the number of medications goes up. We all have seen that the adherence goes down, and many patients can be intolerant to the side effects with medications, which happens to be a big problem. Devices, what is the role of devices? Well, could there be a role in patients who cannot tolerate medications or don't want to take more medications? Possible. However, the things that we have to keep in mind are the responses are not always uniform. There are potential risks that we don't know about. None are currently approved in the US, but we may see that soon. Of most interest, and I think what we are likely to hear most about, again, is renal denervation. It has essentially been resurrected after the death knell from Simplicity Hypertension 3. It has now been resurrected with all the recent studies. Battle reflex amplification that I mentioned with that little device in the carotid, we don't know what the future will be for that particular device, but certainly we're waiting for one of the trial results to come out. So this may be something else that we hear about. So in all, I would say there is cautious optimism about device therapies. So, again, this is an evolving area. We certainly need more insights into who would benefit most. And I think we're definitely going to hear much more about these devices in the next few years. And with that, I'll end. Thank you so much. And I'm happy to take any questions. Thank you.
Thanks so much, Dr. Thomas. This was great. Looking forward to the day when we can start using devices. We all have patients, I think, who have difficulty tolerating a lot of medications or adhering to a complex regimen. I have a more general question. You know, all the big outcome studies that I know of the effectiveness of real-world effectiveness of treating hypertension are based on in-office hypertension measurements, if I'm right. And, you know, all your slides are showing both in-office and ambulatory measurements. And the ambulatory measurements seem to be not as big a drop because obviously patients are tense and have their epi levels and nor-epi levels are higher. Do you think that there is room to just go back and really do some of these studies looking mostly at out-of-office hypertension, or is that episodic hypertension in the office a good surrogate for outcomes? What do you feel?
So I think, like you mentioned, certainly the office being higher is definitely, I think it's a surrogate for the sympathetic overactivity, because there are these old studies that looked at heart rate, poor surrogate, but still patients with a higher heart rate or higher blood pressures, like the white coat effect we see, it's not completely benign. These, although we think of them as benign, they may not be completely benign. So we know that there is something underlying that may cause a sympathetic excitability that is probably not a good sign, at least for future development of hypertension. So it's not the best surrogate, but certainly these are patients who I would think may have a better response, although we don't know that for sure. And as you rightly mentioned, the ambulatory blood pressure responses were not as significant as the office. So certainly there is something there that we can potentially look at. I don't know if the Simplicity trials in the past have actually looked at that effect necessarily, but that is something that I believe would be in the future if as a surrogate marker for patients who might respond much more than somebody who had, no white coat effect, for example. But certainly, we think of white coat effect as a benign thing, but I don't think it's so benign as we think it is. Yeah.
Perfect. Thanks. Vic?
Anybody else? Yes, Thomas. It took a while for that blood pressure to come down, right? You said you showed the first few slides and came down over 3-4 months, and over a year really came down. Does it take that long, and does it keep going, or does it stop at some time to be effective?
So the recent studies, we don't have much data beyond the 6 months. So the Simplicity 1 and 2, which were the initial quote unquote positive trials, non-randomized, they did show effects up to 3 years. So certainly, could there be delayed effects? We don't know. As far as the published studies, we know that those who had efficacy initially, it was persistent up to 3 years. Can they have efficacy beyond 6 months? Can there be people who respond at 1 year? Those are also possible scenarios. Now, as far as the new studies, the spiral studies and the radiance, we still don't know beyond, they haven't published beyond the 6 month period. So it'll be interesting to see what that data looks like, just to sort of get that long-term effect. Because so far, all we know is from what we know from the Simplicity group of studies, which were not randomized. So these randomized trials going forward would be better to answer that question, to see how long these effects last.
And another question would be, we have the GLP-1s that reduce weight, and some people don't respond at all, and some do a fantastic job of responding. Do you also have any idea? I know you said you don't know who's going to respond, but is higher the blood pressure more the response, or that's not so?
That is an interesting question. Although this wasn't proven for sure, again, going back to Simplicity, they looked at that and they saw that the patients who had really high blood pressures are the ones that are more likely to respond. But again, are there any specific characteristics that would point out their likelihood of response is unclear, but certainly if they had higher blood pressures, the likelihood that it comes down by 5 points or 10 points is much more. And the same thing with a higher heart rate. That's what they saw as well. So again, going to Neil's point about this hyperexcitability issue, they did not think that this was enough of a sort of a target to say, hey, these are the patients who would definitely we should be looking at. But certainly when they looked at least some of the data, they found that the patients with the highest blood pressures and higher heart rate may be more likely to respond.
And definitely need more studies too.
At this point, it's a little unclear. But the reason they went back to the drawing table and sort of did this sort of without medications and everything is to take out the noise from whatever medications are added, and just even to see if this is even something that would work. And now that they have the proof from these newer studies that this is something that seems to work, I'm sure there's going to be more studies trying to figure out which patients would be most likely to respond.
So
one quick question.
More life to it to kill the nerve.
Yeah. So George, if I remember right, you were saying the initial studies that were done, the surgical denervation back in the 50s, they got a systolic drop of 30 or so, with people becoming orthostatic, some such huge number. And we are not seeing that with the devices. And sorry, go on. So is that because we are missing some of the nerves? Is it still something that is worth looking at?
Yeah, I think that's what it is. So it's not like you're cutting off the entire sort of sympathetic signaling, but you're trying to get enough to decrease that hyperinnervation, so to speak, decrease that sympathetic activity to a point. We don't know how much, but at least we assume that these are patients who are sympathetically hyperactive, at least with the resistant hypertension or refractory hypertension. And instead of just cutting off everything, we are just targeting enough so that we can decrease that signaling, not completely. You still mount a response, but where that fine line is, between how much we get versus what is too much is also unclear. So there's no way to map this. And all these newer devices that are coming out are to try and target more nerves. But how many should we eventually target to get a response without side effects? It's not known. At least with these devices so far, they haven't reported any significant orthostatic hypotension or any downsides yet. Long term, unclear.
Great. Vic, you want to close?
Oh, no, I'm great. Thanks for the talk. And it was really nice to have all the speakers. Nice to learn new things today. And I'll give it over to Neil to wrap it up. I think thanks to everybody for the support, and thanks to all the people who've attended today. And hope we have another one next year.
Great. And, thank you, Vic, for all the hard work that went into making this happen. I just showed up today, but you had everything lined up. It was great. And thanks to all the participants, and thanks to all the speakers. Look forward to seeing some of you this evening at the event. And thanks, Dr. Thomas. Take care.
Oh, thank you. Thank you so much. It was wonderful. Thanks.
Thank you.
Bye.